All right. Good morning, guys. I'm Dr. Jenny, user physical therapist and doctor of physical therapy. Today, for our thanks God, it's Thursday, we have Dr. Helena Esmonde. She's a physical therapist, doctor of physical therapy, and a board certified clinical specialist in neurology, right? Okay.
That's right, you got
Yes, yes.
it.
And she's a physical therapist practicing in Pennsylvania. Am I
That's
right?
right. That's
Okay.
right.
And so thank you so much, Helena, for your time. And this is a great opportunity for us. One of our members in Balance and Fall Support Group wanted to do more or have a great topic regarding vestibular. And you are one of our great physical therapists. And in addition to Asha, also doing telehealth and vestibular because she's also a neuro certified specialist. So thank you so much for having us here in Balance and Fall Support Group. So tell us more about yourself.
Oh, thank you. I appreciate being here, Jenny, Dr. Jenny. Um, um,
Thank you.
so yeah, no, my pleasure. Yeah, I've been a physical therapist for 14 years, almost 15, and I've been doing vestibular care for about at least 10, maybe even 12, if I did the math right here. And so, I worked in the hospital setting first. And, you'd have patients come in with dizziness, and it could be anything. It could be dehydration. It could be electrolyte issues. There are many, many causes of dizziness, which is why it's really a difficult thing sometimes for patients to figure out what's going on and for their doctors as well. And so I felt that a physical therapist could really be a helpful team member because we have the opportunity to become, if we choose, specialized in inner ear balance disorders, which is what vestibular means. So it's important, to have a team when you're looking at dizziness because so many causes occur, and you could have more than one at the same time. So it's not always, a simple case. So that's where kind of vestibular therapy comes in. So I got excited about that at the hospital to help, problem solve and be the sleuth and the detective and figure out what's going on, because there's not always a test. A brain scan may not show something like vestibular migraine, which is one of the most common causes of vertigo, actually. And it's just not a good test for it. So it's really about taking a good history and kind of taking the big picture of what's going on and how people respond to certain treatments.
Yes, yes, that's really interesting. You just said, in addition of being a physical therapist, you're also the co-founder of Vestibular First. So what do you mean by Vestibular First? Is it like a clinic or an organization? So tell us more about it.
That's a great question. So actually, Vestibular First is a medical device company. And what we're doing is we're making affordable infrared video goggles. So these are an important tool for clinicians who are treating and examining patients with vestibular issues or possible vestibular issues, trying to rule that out in some cases. And so these goggles have been around in various forms since the 1970s, but unfortunately, they have been pretty expensive. So only, about 60% of vestibular clinicians who are trained don't have access to this technology, unfortunately, because of the cost. So what we've decided to do, myself and my husband, Patrick, who's the other co-founder, is we wanted to make it affordable, and we figured out some ways to do that through having a small overhead and streamlining our costs. Because we're really committed to making this technology accessible to clinicians, because we know that it makes a huge difference in accuracy for the diagnosis, and then, of course, choosing the right treatments would result from the right diagnosis. So we want to get patients better faster. And unfortunately, in room light, when you're doing an exam, you're missing about 2/3 of the abnormal eye movements that you would see. So it's really critical. And this is even compared to the old school thickened lens Frenzels that you could use. You're losing 2/3 of abnormal eye movements there, and probably more in room light. So it's really important to do that visual fixation removed or dark, no light exam. And that's what these goggles allow. So, on the inside, they have the cameras. This is our upgraded version, which we're going to release. We're planning to release in April if everything goes according to plan.
Congratulations.
FDA clearance is pending, so we haven't officially got FDA yet, but we're working on that.
Yes.
But they'll have visual fixation lights, which are really important, so that when it's dark and then you put the light on, what the eye movements do whether they decrease or they stay the same, can be really helpful in figuring out, is this more of a brain problem or more of an inner ear problem, things like that.
Good.
You know, we really strive to make it comfortable, to make it easy to use for the clinician. We have a quick release, so if you want to take the goggles off quickly because the patient needs a break or they're not feeling well, something like that. And it makes it easier to put on for people with like different hairstyles and ponytails and things. So we really tried to kind of address a lot of problems that I as a clinician have run into using different kinds of goggles in the past, because I've been lucky enough to be in settings that did have them. So I'm glad for the opportunity to kind of put my dreams into reality a little bit. Yeah.
That's awesome, because what I used before is only the Frenzel, right? Yeah, because when I did my what do you call this, like courses or seminars, that's what they're just showing to us, how to use that and everything. And it's a little bit heavy, so this looks like light and portable.
Yeah, it's only about a half a pound. We really try to make it as light and as short and as clean as possible, frankly.
Yeah, how much is the so we call it like video goggles?
Yeah, you can call them infrared video goggles or video frenzels. You'll hear a lot of different ways. Yeah.
How much is that? Because you said it's more affordable than what we have right now in the market.
Great question. So most of them on the market are, if you're really stretching the dollars, you might get one for $5,000. Most are $8,000 to $10,000 for a system. Ours, with our upgraded version, which will be released, we're offering a pre-order for $1,250. And when they are released, it'll be $1,500. So it's very much well below the cost of the others on the market. Now, there's some features that some people look for in the more advanced versions that we don't offer. So they usually, those advanced versions have like room light testing as well. And this version is not that. It only does the visual fixation remove testing. Most clinicians, it's all they need anyway. So it's not really an issue. And so that's why we call this our entry-level goggle. We're planning to create a more advanced version that would do more of that kind of advanced testing and have software with, you know, the full data reports and everything that some researchers might want, things like that. But, you know, for your kind of regular clinician out there in the field, in the trenches, trying to take care of patients, this should, you know, more than do the job for most. So we're pleased to offer that, you know, to help those clinicians. And I really think, you know, a clinician can be very well trained, but unfortunately, without the proper equipment, they're just, you know, not as well equipped to do that care. And so it really, I think patients, if they start kind of saying, hey, do you have these infrared video goggles, you know, kind of, I don't want to say demanding, but really requesting like, hey, this is the standard of care. This is what the research says is important. So, you know, we can get the best care. I hope that will help to encourage. Clinicians usually want them. It's the administrators sometimes because they have to, you know, contain costs and things. So even though ours are very affordable, it still costs something. It's not free. So, you know, I'm hopeful that will, you know, go out there, everybody, all those patients, and say, hey, you know, I have dizziness. I want to get the best care. You know, who has these and who has, you know, the right technology as well as the right training.
Yes. So is it more on inpatient or in a clinic that you can use it, or in any setting?
You can use it in any setting. I mean, we really try to make them, so that's why we use the disposable cushion right now. So that's going to allow for inpatient settings because they can use a fresh cushion between every patient in the hospital or a rehab setting. But you definitely would use them in outpatient as well. And I think I've got clinicians out there doing home care. So they're taking the goggles, you know, kind of between homes along with their laptop. Because that's a critical piece for the goggles to function. So, you know, really, I see it being used in all settings because you can have dizziness anywhere, anytime, unfortunately, and it can really impede your ability to progress. This is the issue at the hospital. You have patients with dizziness, you know, come in, we ruled out stroke and all these other things and say, oh, it's probably just, you know, crystals out of place in your inner ear, a very common problem, BPPV. And yet nobody knew how to fix it. You know, these physicians, they're wonderful, but they just didn't know that. That wasn't something they'd been trained in. And so they wanted to send these poor 70 and 80-year-old ladies who were kind of falling over because they're so off balance from the crystals being out of place to a rehab setting. And it's like, wait a second, I think I can really get these back in place in a session or two. And then they were better and they could go home. And so it's really, you know, again, critical in all settings, I think, to be, you know, looking at these patients, saying, is what's going on? And is this something that we can address efficiently? You know, to reduce costs for, you know, medical care always skyrocketing. So, you know, sending someone into a rehab unnecessarily, you know, $700 a day, you know what I mean? Like,
I super agree with that. Especially I work in inpatient, I work in home setting, in mobile PD, and then we have many cases like they're coming from their home. they had a fall. So the history retaking, right? So this client already, probably there's a balance issues, but we really need to know, is it central or some other issues, right? So peripheral. So, and then once they diagnose that, they will just sometimes doesn't get the root. It's just, as you've said, it's just easy. Okay, it's just vertigo. Oh, okay, or dizziness. Here's the medicine for dizziness. If it is
Which
vertigo,
doesn't work.
yeah,
God, I
which
mean,
is
not in most cases. Meclizine, which is
mm,
the medication that's most commonly prescribed for
yes,
dizziness, has a role, but it's really in the literature only shown to be useful in acute stroke when you're very nauseous and you're leaning over
mm-hmm.
and you're in that acute recovery phase. But most issues, the majority, there's no change. If anything, it makes people sleepy, which is going to make them more unsafe. So
Yes,
I really
yes.
hesitate, with meclizine. I think that there is a change happening slowly,
Mm-hmm.
amongst physicians, but, they still want to give something to the patient, and they, again, may not know maneuvers, so they don't know how
Mm-hmm.
to, treat the crystal problem if that's the issue. So,
That's
they're
true.
giving this meclizine, and it's like, let's refer properly. Let's get them to a clinician who, does have the right equipment and training and can get this taken
Yes.
care of.
Yes, that's true. And in addition to that, let's say we need to know when will be the bottom of the, or the, what do you call this, the ceiling effect of that meclizine. If this particular client is using that for chronically, like for a long time, you need to check again. That's what I always ask. When was the last time you checked your ears? And then when was the last time you checked with your ENT? Do you have your ENT? And then the caregiver will say that, oh, the primary care physician checked his ears, and then yeah, he has an earwax, things like that. There's one earwax here and one here, and that's what my issues before when I was in college, and they did the BPPV and those things like Dix-Sulfide. So what the importance here is, as you've said, diagnostically, we as clinicians need to know the root. Once we need to know what's next, right? So the next
Right.
will be is more on properly diagnosing it, and this will help. The goggles, video goggles will help. And when we use that, we will know the root of it, because we can distinguish, is it like specific dizziness, if it's vertigo. Okay, all right. So do we need to be like certified in urology to use that, or to have more trainings with vestibular?
Yeah,
So
I mean, I think that the key, for a clinician to be prepared to treat these patients is certainly at a minimum to take what they call a basic course. I have quite a few listed on my website that I recommend, vestibularfirst.com, and there's an education article I wrote that talks about, developing your skills as a vestibular clinician. So, certainly at a baseline, going to a basic course. And then to me, if you're at all wanting to really help these patients, you need a second course minimum. So that's 2 courses minimum for weekends. And then if you really want to get into it and you want to serve this population well, there are wonderful courses. There's one in particular, it's a little hard to get into, but it's fantastic. It's through Emory in Atlanta. It's
yes.
the vestibular certification. They don't call it a certification because officially that has to be designated by the APTA, or American Physical Therapy Association, and they haven't been
Oh,
able to
okay.
agree on the criteria. So you'll hear different people say they're certified. All that means is they're certified in Joe Schmo, whoever it was, said, this is my technique, this is my course,
Okay.
and you're certified in that. So Emory actually does not call themselves certification. They call themselves a competency-based course, which means you had to take written tests, a practical where you're doing physical exam techniques, and then you're watching eye movements on a video, and you're saying, this is what I think the diagnosis was me. So it's very thorough testing,
Yes,
and
yes.
that's why it's basically considered one of the gold standards. There are other great ones out there. It's not the only one to take, but
That's
I was
great.
lucky enough to take it, so I'm more familiar with it than some of the others. But I think ultimately it's time in the classroom. If you're only there for a half a day, you're not certified. That's not enough time. You need experience with these patients, ideally a mentor. Luckily, the American Physical Therapy Association, the Academy of Neurology, they have mentorship pairing. So I'm actually paired with someone who emails me questions, and we can share video as long as it's HIPAA protected and the patient has agreed for their video to be shared. We can really talk through cases, and I think that's key. For ongoing training, it's not just a one and done. I'm going to ongoing courses. I'm reading articles. I'm going on to Vestibular Today, which is a great website. They have a ton of educational
Oh,
information. and then vestibular.org, which is the Vestibular Disorders Association's website. That's great for patient education, but there's tons of resources for clinicians as well. So I think, you know, just being hungry for that and you know, going for ongoing training is really important.
That's good. That's good. So we have many different niche. So when do you feel during your physical therapy that you want vestibular? Because I'm more on geriatric. I'm more on, but I can see those cases because I did my vestibular also courses in Texas. I attended one of the University of Texas there. And then,
Awesome.
yeah, that's where I love the part that you're going to see those kinds of like the utricle saccules and everything. Then I myself feel dizzy with those training. I said, oh my goodness.
Yeah, the anatomy is pretty wild inside the inner ear. It's very unique.
So I feel that I have those like hypo, you know, my vertigo. So I said, oh my God, I don't want to be the model here. And then, why don't you just
yeah, I mean,
do the
it's very
model?
common. So certainly experiencing it can bring you to the interest. But I think ultimately, you know, I don't think, my opinion, that you can be a great neurotherapist, frankly, without knowing vestibular. And I don't think you can be a great sports physical therapist without knowing vestibular, because unfortunately we have a concussion issue going on as far as the sports world. So, you know, I think, to me, I think my Queen of France, as they say, whether I could have anything I wanted, I would have most physical therapists, if not all, and other clinicians out there too, ENTs, audiologists, all feel comfortable with a basic anatomy knowledge and a basic understanding of the most common conditions and some signs and symptoms. Not everyone has to be an expert treating, because, you know, maybe that's not your you know, your gig. It's not what you want to be doing. But I think, you know, gosh, all these patients I've had who are falls issues, they're not complaining of dizziness at all. I do a quick vestibular screen, and often I find BPPV or a hypofunction or even a sign of an old central vestibular issue. And if we do not work on that aspect of care, their balance may not improve, or not very much. So it's really, you know, it's a deficit there that you're just, you know, kind of leaving on the table or ignoring, and that may, you know, really be an issue for the patient if they don't get that care. So not everybody's going to complain of dizziness, but they could still have a vestibular issue. So, you know, luckily for me, I have a lot of interest in training, so that's one of my quick go-tos. And if it's all negative and everything looks good, great. We're going to work on strength and flexibility and, you know, sensory input, vision, whatever it is that, you know, we can see are contributing to their imbalance. So it's different for everybody. So you got to look at the big picture. And I think that's really critical.
That's really good. Especially you're the first person from the inpatient. You can really check and follow through for the home. I'm more on the home. So whenever we see that we can do something with our clients, so we really need to inform and give them the best care. We keep doing the balance training is good, but if we didn't really improve more on the root of what's the problem, so we're really not really taking care of it, you know, just like covering the wound, but we didn't get the tumor, something like that. So, so as a surgeon, pretend like I'm just so I'm just watching house. So I'm a little bit. Yeah. So we really need, as a clinicians, to have the basic. If you really need to go into, you're suggesting that if we love this field, so that's a really good point. And then we have all the different resources available for us, and we really thank you for making this affordable. And you know, in our, as a clinicians, we can have these kinds of devices, and then it will make us more able to serve our community, because if you have this particular one, more and more will able to do it, because it's a little bit more affordable, you know. As you said, you get your dream come true. And I'm sure we have many clinicians that is also, I have many colleagues, they are in outpatient setting, and I have vestibular specialist colleagues as well, that they do that, but they're really not doing it too much because of the less things that is what they call available in their clinic. Yeah. There are many. I remember. Can you? What is the most common cases that you encountered, and a little bit of basic physical therapy or balance exercise that you can suggest to our Balance and Fall support group members?
Sure. So, I mean, the most common causes of vertigo, you know, we might have to differentiate, because dizziness and vertigo is more of a spinning sensation that some people might describe. Dizziness could be anything, lightheaded, off feeling, something's not right, I'm tipping, I'm drifting to the side when I'm walking, things like that. So, you know, it really varies on the descriptors. So what I'm more interested in, of course, is my exam. And, you know, the most common issues that come up are, as I mentioned, BPPV, these crystals out of place, extremely common, brings tons of people to the ER every year, millions. And that can come and go. So it's really a tough one because, you know, you might have the crystals out of place in our little inner ear one moment, and then the next day they could be back in place, but they could go out of place again 2 weeks later or a year later. So it's really tough. So that's where, you know, kind of getting that diagnosis when you're having the symptoms so that the clinician can see those eye movements that would go with that to say, yep, that's what's going on. And then you kind of unfortunately might get to know that feeling. And if it comes back, you say, oh, there it is again. And then you seek care with the person that you know and trust. You know, and vestibular.org has a great providers site where you can search, and I really recommend using that to find someone in your area who, you know, is more likely to be, you know, highly trained if they've decided to be on that website. So I think beyond that, when you're talking about basic imbalance, I recommend a lot of people do what I call, and I've heard other people call grounding. It's where you kind of plant yourself either seated or standing. You've got your back to the chair against the wall. Your knees are slightly bent. You're putting your feet flat and pressing down. You want to connect to your sensory input of your body. That is generally, in most people, unless you have certain conditions like MS might be a little tougher, but that's your reliable information. So the inner ear might be telling you the straight is over here, but your body is saying, no, straight is here. So your brain is trying to figure out who to trust. That's what I like to say. So, you know, if we can kind of at least connect with that body input, that can at least reduce some sense of dizziness or imbalance when it's in the moment. It's just a safety strategy, really. It's not a long-term solution, but it's certainly something to do, you know, if you're starting to feel elevated symptoms, which could kind of, again, get to the point of where you're really unsafe or, you know, feeling really unwell. So I think grounding is a good basic technique. Again, not a long-term solution, but, you know, guided therapy, to be frank, is the best, because then you're going to be able to address your individual issues. You know, not everybody has a strength issue. Some people are perfectly strong, but they're still off balance. So, you know, it's really about saying, you know, what are the elements going on for you, you know, and how do we address those? Because the treatment for crystals going out of place is to move the head and body to put them back where they belong, which is highly effective. If done well by a skilled clinician, it's between 80 and 90% effective. So that's pretty awesome for a treatment. Whereas if it's more, say, vestibular migraine, now we're talking about education. How do I reduce how often I get migraines by avoiding my triggers? And you have to kind of track things, and it's really more involved. So those patients I see over weeks and weeks just for more for education, and then, you know, some balance training and things that they likely need. So, you know, it's really about what's going on for you. You know, people say, oh, stand on one leg and just practice balance. That might work. But unfortunately, depending on your issue, that might not change anything. So I think I don't like to give like kind of blanket balance advice, unfortunately. I like to really, you know, drill down and say, all right, you know, what's going on here? And then if you get a good therapist, they should be able to give you things to do at home and to do on your own, and to do more for long term once they discharge you, you know, and then to kind of know what happens if things flare up and you can't manage it on your own. That's the best thing.
Yeah, that's awesome. That's great tips there. Yeah, I remember there is also like some basic exercises, depends on what your condition, that they can just practice at home, like habituation. You just try to just do your ocular. So they need to know first what's really their issues, and then that's also important more in education, because once you see them, once you know the really problem, they will be more aware that this is the issue why I have this problem before. So what's the most common history, like why it recurs or it occurs to our clients? Let's say BPPV or some of the history that they keep.
Sure. And the good news, just to cap off to what you said, is that telehealth is very amenable to this condition or series of conditions. So not everybody needs physical maneuvers, which probably you're going to need to do more in person generally. You know, and for people who it's more of an inner ear issue or even a brain issue, sometimes just, you know, being guided through exercises that can be done remotely, and that's a good thing. You know, balance is a little tougher because you might need a family member to guard you to make sure you're safe as you practice balance, things like that. But, you know, I think there's definitely a blend that can happen, and that's great because, you know, sometimes getting to a clinic can be an issue for patients. So we want to make sure we're optimizing, you know, how we approach the care. But if they have neck issues, which is also unfortunately very common, it may cause dizziness to have a neck issue, but also many people with dizziness just start to be really guarded because they don't want to turn their head and stimulate the dizziness. So then they just get these secondary neck pain and neck complaints. So, you know, again, if they need neck care, sometimes you need to be in person to do like the manual part of that, if that's what's appropriate. So I think as far as your question a moment ago, we were asking about kind of what leads these patients to have these conditions. Some of these conditions are what we call idiopathic, meaning we don't know why it happens, but a certain amount of people are going to get this condition. So the crystal's out of place, again, the most common, that is generally idiopathic. However, it is more common in people with a history of migraine, with a history of head trauma, with osteoporosis. And this has to do with kind of theories about the crystals and that they're calcium carbonate and they're supposed to be binding to a surface, and if they break free and float, they're more likely to find their way into a canal. So different things that really disturb the kind of the
anatomy.
Yes, the anatomy, exactly. It goes back to the anatomy, then you might see an uptick in BPPV, but there are plenty of people who have none of those things and get BPPV, so it's not a one-to-one by any means. Other issues, vestibular migraine is mostly genetic, although it's more common in women as well. Unfortunately, we think there's a hormonal influence for some of this. And there are plenty of women who used to get a lot of headaches with migraine who don't get any headaches, but now just get rounds of dizziness postmenopausal. This is very common. So, you know, people think migraine has to equal headache, not necessarily. You may have no headache, but that's the cause of your dizziness. So it's good to look at that as a possible cause. And then we have other conditions that are serious, like strokes and brain tumors, multiple sclerosis, that are all considered central. So they're affecting the brain or the spinal cord, and they can cause dizziness. So, you know, that's one of those things where we usually want to rule that out with a good exam. And sometimes they need imaging, like an MRI of the head to confirm that it's not that. And if I see certain eye movements, that might lead me that I think that could be going on. That's where I'm referring absolutely to a neurologist. So that's very important. Also migraine, I refer to neurology just in case they need medication to help manage and reduce the frequency. So it's very important to have people on call. Concussion, which we usually know the cause because they usually know they fell or hit their head or were in a car accident. Hopefully we can figure that one out. Although sometimes they don't realize it until several weeks out. Like, why haven't I been feeling bad? Oh yeah, I kind of hit my head really, really hard when I was getting out of the car, and I've been feeling bad, you know, ever since, pretty much. So sometimes it's a delayed diagnosis there, but ultimately that's where I want a team. At a minimum, I want a physician on board to help monitor the situation. They might need medication to manage things like headache. And then also sometimes they have ocular issues where I'm referring to a neurooptometrist. You know, so it's really good to kind of know with your situation, wow, do I need somebody else on my team? Not that physical therapy isn't great, but you know, even functional neurologists who are chiropractors, they can do special manual techniques. It's really, you know, good to look at the individual and say, you know, what's going to help serve this patient best? You know, because I can't do everything and I don't know everything, and I shouldn't, you know what I mean? Like, you know, it's always good to kind of look at the big picture. And, you know, vision is important for all patients. So even my elderly, how long has it been since they've been to the eye doctor? Hearing has a huge impact on balance, believe it or not, because you're actually using echoing and things bouncing off to judge your distances. They've shown this in children who are born without hearing, that it changes the way they can judge their space. Even if they don't have vestibular involvement, although many do, because those structures live right next to each other. So, you know, it's like everything, you know, fits in. And so sometimes that can seem overwhelming, but I think if you just kind of take it piece by piece and say, well, what do we need to work on? What's our low-hanging fruit? What can I kind of conquer first? Oh, neck, I can definitely help the neck. So let's help the neck, and then we'll start moving better. And just by moving, we're stimulating the vestibular system. So that's a plus. So, you know, you have to kind of look at all those pieces. And then there are great tools out there for more involved patients, like the balance wear vest, which is a weighted vest.
I like that.
You may be familiar with that. So that's a great tool for certain patients. Really can make a difference in their balance, especially central conditions I found. Parkinson's even, things like that.
MS.
MS, definitely. So yeah, so a lot of our patients, I'm looking at that. So it really just depends, again, coming back to what's going on now, and what happened when you got dizzy 5 years ago could be different than why you're dizzy now. So again, it's important to get that exam and say, you know, what's going on right now? And like, you know, sometimes it's the same. you know? So I think people get caught up sometimes in, well, this must be this again. Well, not necessarily. It's not always your medication side effect, although it
Yes.
can be. So, you know,
Mm-hmm.
we got, you know this. So, you know, it's good to kind of keep taking a look and just problem solving and getting that team of medical brains together to
Yes.
say, you know, what's going on here and how can we help?
That's really awesome. That's true. So history taking is the key because of all the things that you've said. They are really going, it's coming from them. The exact definition, that's where we're heading. And then in addition to that, we're the one going to help them with diagnose with the proper gears and everything. And then when they said exactly, or I have difficulty every time I go outside, I have these things. Oh, okay, photophobia. You will just click, okay, check. You know, okay, check. And then what else? What's going on? And what time of the day? What are you doing when it happens? Is it just, you know, by proper questioning, the proper history taking, it adds up in the
Yes.
proper definition of what's the
Yes.
issue. And I
And the
like when you
literature and
explain.
the literature supports that. You're 100% right. And there's some cool tools out there that are being developed. So there's something called the Dizziness Symptom Profile
Mm-hmm.
out of Vanderbilt. Dr. Gary Jacobson is developing it, and it is really designed for physicians and you know, kind of physician offices, staff,
Mm-hmm.
to kind of help them, because you and I, you know, as clinicians, and you start to hear the same stories, you're like, oh, this
Mm-hmm.
sounds like another migraine patient. You know, they start to
Mm-hmm.
kind of have a general pattern.
Oh.
But, you know, as a physician, they may not, you know, be able to catch that pattern because they're not vestibular specialists specifically.
Mm-hmm.
So the questionnaire that he developed really helps to kind of do that. And so there's a
Good.
scoring system. And if you answer high on certain questions that you and I would say, oh, that sounds like migraine, then
Mm-hmm.
that will pop up as a possible diagnosis. So it really helps to guide. And I think, you know, he's still working on validating it, but I'm hoping to see it, you know, as a part of the long-term solution. I actually would like to see physicians doing, or their staff doing a basic vestibular exam with goggles,
Mm-hmm.
plugging that data in. We're hoping in the next few years to, you know, have some sort of software that can kind of come back and say, wow, these eye movements most look like posterior canal BPPV when you put them in this
Mm-hmm.
position. So, you know, I think there's great excitement on the horizon for, you know, kind of not having everyone need to be an expert, but having good, immediate, you know, kind of ways
Yes.
to get more objective data to say, yeah, when they answered this way on the questionnaire, for example, it's got to be, you know, leaning towards A or B here. Let's, you know, think about checking those out or referring to a neurologist or who, you know, a
Mm-hmm.
physical therapist, whoever's appropriate, you know, to kind of go further with these patients.
That's true. And they will lessen all those medications as well because it adds up on their, and there is a drug interaction, you'll never know. And then it's very important, the compliance. If the client knows already what's exactly the issue, they keep taking their medication and then they still feel that. And then they will going to have at high risk for falls still. So from the beginning, we'll try. And I like what you just said, the team approach. We need to refer for the specialists. We need to have our neurologist. We have an ENT. I like the chiropractor as well for the neck and everything. So that's really, really awesome. So as a physical therapist, and also it is our role to explain exactly regarding the migraine, just go back to the migraine. um, there is also sometimes diet that they can help them to lessen the effects of the migraine. So let's say I remember lessen the cheese, peanuts, and then these
Right,
things,
but it's
right?
not the same for everybody. So you could have
Yes.
person A eats an aged cheese, boom, instant migraine every time. Person
Uh-huh.
B could eat every aged cheese in the
Peanuts,
world. They feel no
no
different. But if they
problem.
eat aged cheese and they drink red wine at the same time, now person C gets a migraine. So again, that's where I think individualized tracking a little bit
Uh-huh.
and saying, wow, can I really like see what's going
Mm-hmm.
on here? And some people choose just to eliminate things that could cause it just to kind of not have to worry about it. That's a choice you can make. Other ones want
Mm-hmm.
to really kind of systematically rule in or out certain ones. You know, it probably depends on
Mm-hmm.
how much you love something. If you don't care about aged cheese anyway, then hey, I don't care if I don't eat aged cheese again, then fine, no big deal. But, you know, it really depends on the person. I think being smart
Mm-hmm.
about it and not just kind of being random and just saying, oh, well, yeah, I guess I had dairy this week. I don't know if it affected me or not. You know, it's not really helping you then, you know, and I think that's the commitment that a patient unfortunately has to make sometimes, is say, yeah, I really want to figure this out
Yes.
and, you know, be able to make the choices that I figured out. Yeah, when I get
Mm-hmm.
dehydrated and I don't sleep, that's really when I get the migraines. Other than that, I'm fine. You know,
Mm-hmm.
then you got to kind of figure that out for you. And other people, you know, it's really, they're very sensitive to a lot of triggers. So it's like even weather changes, which you cannot control the weather unless you move somewhere else, like, you know. But then if you know that, hey, a weather system's coming, let me make sure I'm really well hydrated and I get great sleep. And I, you know, you're going to fortify yourself so that the hope is that if you get one, it'll be mild, or maybe you won't get one at all. And again, that's where medications come in. So you know that early sign of migraine, you take your, what they call an abortive med right away, hopefully can kind of cut off, reduce or eliminate the kickstart of the migraine. You know, it's a management situation at that point. And I think that's something you're figuring out. And some people told me, yeah, I knew this chocolate was going to give me a headache, but I didn't care because I really felt like it. Hey, like, that's your choice, you know, like, so you're an adult. If it's not going to cause, you know, harm to others, and you're making the choice that you're, you know, you want to do that, then okay. But, you know, just being educated, I think, is 99% of it, because most people don't realize that something's, you know, even a migraine, or that it's causing, you know, their symptoms. So I think that's really key.
Yeah, that's really, really good. Imagine the vestibular. It's only one topic, but it goes like from ears to eyes, and then the brain. Oh my. And then we have this is really a complex one. And that's really important, because from the eyes is vestibular. The ears is vestibular. Equilibrium, that's it. That's the vestibular issues there. And then now with some also of our histories, comorbidities of the stroke, histories of stroke, then trauma is still vestibular, TBI, So it's really complex. And then overall will be more on your balance. And then if you didn't check on this can lead to depression as well, because how can you go, I don't want to join you because I feel dizzy. I don't want to go to the party because I have vertigo.
Yes, social isolation. Absolutely. And cognitive deficit, because they've shown, for example, in people with, say they have a history of an infection in their inner ear that affected the vestibular nerve on one side, causing a hypofunction. Those patients, they've shown, automatically decline in cognitive status, because the brain has to take over the job essentially of the inner ear and do something called adaptation. So when the brain has to do that on a permanent basis, because that nerve usually doesn't come back fully, unfortunately, that's the nature of nerves, they don't tend to fully heal once damaged. Then the brain has to kind of do that job all the time. It's used up resources that are not available for other cognitive tasks. So these patients have more problems multitasking, dual tasking. So if the phone rings and I was trying to walk somewhere, I go to get the phone and I'm tripping, you know what I mean? Like, so these are real issues for our patients to, you know, somebody calls their name and they turn their head and boom, they're off to the side, you know? So I think we don't always realize that the impact of vestibular condition is not just to be dizzy or off balance, but it actually affects your cognitive status as well. So, you know, there's a lot of levels.
That's awesome. So in everything that we discussed today, what will be your main tips for us as for our clinicians, and for us as a clinician, and also for the Balance and Fall support group member as an aging adult, you know, as a client? So what can you just give us?
Right. So for the clinicians, I think, you know, I love being part of a team and asking questions, and just never feel like you know too much. Keep asking, keep taking courses. There's great online courses as well as in person. You know, if you're busy, just, you know, try to make it a priority, even if vestibular is not your primary population, you know, maybe once a year, every other year, you know, kind of keep that going. And then I think for patients, or, you know, people of the support group, you know, just at least once a year, to me, I recommend anybody who's got a concern about balance to get what I call a tune-up. So they come in for physical therapy for a certain amount of time, even if they've been doing their home program and they're A+, and that's great, which most of us are not going to be A+, because it's just life, you know, to stay on top of it, because it only takes one bad fall to break a hip, and we know there's mortality associated with that. You know, falling and causing, getting yourself a concussion as a 70-year-old, that's a really big deal. You know, that's brain injury. And so it's really, you know, if you want to have quality of life and live a long, healthy life, just stay on top of it, you know, keep exercising, but beyond that, really think about getting at least a yearly tune-up, you know, where you're getting checked by some specialist, and particularly, you know, physical therapy is well suited for that, but certainly there are others who might be able to, you know, kind of be part of your team. But, you know, just trying to be proactive, I think, is really important.
Yeah, that's true. Because their primary care will really never know if they don't get there. And then referral is very important for the proper specialist and everything, you know. And then, so thank you so much, Dr. Helena. So how can we connect with you? So how can we contact you and everything?
Sure, sure. So certainly you can go to our website, vestibularfirst.com, and there's a contact us section, and you can use that. I also treat patients, as I mentioned. So I'm here in a suburb of Philadelphia called Broomall, and the place I work is Advanced Physical and Aquatic Therapy. And there's one in Springfield, PA, and there's one in Broomall, and I'm at the Broomall site. So you can find us on the web at Aquatic PT. And then, of course, you can email me direct, helena@vestibularfirst.com. And my name is spelled Helena, just like the
Yeah.
capital Montana, if you like your capitals.
Yeah, I graduated in Montana. I saw Montana, and they have the big M, and they have like a tradition that when you were there, try to go there on that
Yeah.
big M. I I said,
Yeah, I gotta make it up there someday. I've never been to the capital, which I really, really should, since
yeah,
it's my name.
it is in University of Montana, so it is there. So I think in Missoula. So
Yeah,
that
it's
is in Missoula.
beautiful.
So yeah, yeah,
Awesome.
yeah. So phone numbers and everything. So it's in Vestibular First,
All
right?
on vestibularfirst.com. Yep, it's the easiest way.
And then if ever they're interested with those video goggles, and then with your goggles, infrared goggles, so are
Hmm.
you doing like a presentation and then in their company or in their clinic, things like that? Just
Right. So basically, if a clinician is interested in the goggles, they can reach out to us. I'm happy to do a remote demonstration, which always goes really well. Very easy for people to do and fit into their schedule because everybody's busy. And then, if they have any questions, they can also reach out, just ask the questions, via email or whatever works. Call our main number, 215-667-8990, but that's on the website. Just any way they have questions, and then I'm happy to, help and work out any questions they have so that they can get the right equipment to take care of their
yes,
patients.
yes, that's great. I'm from Delaware, so how far are you able to serve?
Well, I only do in-person demos about an hour away max, but again, the
Mm-hmm.
remote demos have worked really well. I mean, I
Okay.
haven't had anybody who really couldn't do a quick video conference. Doesn't take a lot of time, and I can show them all the features of the software that we
Mm-hmm.
recommend using the goggles with, and then the features of the goggles themselves. So it's really, I've done as quick as 15 minutes for somebody who was really in a rush.
Okay.
And if they have a lot of questions, it might take a half hour or 40 minutes, but that's rare. So.
Yeah, last question. I remember you told me about the portable, the goggles. Can you show how can we clean that or the hygiene? Because you said that it can be used in inpatient or outpatient or I'm home, so in
Yeah.
mobile. So
Yeah,
how
so
does it work?
again, with our upgraded goggles, it's a disposable cushion right now. We are working on a durable
Disposable.
cushion, but it's not ready yet. The durable one and the body of the goggles themselves would be able to be wiped down the way you would wipe down your walker or any other piece of equipment. So you're using your
Gotcha.
basic, Oxa wipe or whatever, brand you're using. They're all kind of similar, I think.
Mm-hmm.
Obviously, if it's a certain condition like C. diff, then you would use, bleach and that kind of thing. So all of this is perfectly that's how we did the silicone strap and everything. So it would be very
Okay.
suitable to any clinical environment that needed to maintain our cleanliness and
Yes.
infection control precautions.
Exactly. Thank you so That's awesome, Dr. Helena Esmonde. So thanks once again. And then thank you so much, guys. So for the Thanks God, it's Thursday. We have Dr. Helena Esmonde, and she's the co-founder of Vestibular First, physical therapist and doctor of physical therapist and certified in neurology. So she's a neurology specialist. So if you have any questions, any issues, and then if you're interested in her infrared goggles, so you can connect in her Vestibular First. All right, and thank you so much, guys. It's me once again, Dr. Jenny, physical therapist and doctor of physical therapy, board certified in geriatrics. We are here for you. If you have any questions, check out our balance and fall support group in aging adult and also in Physiogen PT and wellness. So thanks again, Dr. Helena. I'll chat with you
Thank
soon.
you.
Okay. All
All
right.
right.
Have a great day
You
and
too.
God bless. Bye bye.
Bye.